Assalamu alaikum. My name is Subanas. My roll number is PP1650239. My group number is 6. The topic that was assigned to our group was end of life care, and the topic that I have chosen is pain management. End of life care. The main objective of end of life care is basically to improve the quality of life for the patient as well as for the family in the last days of his life. It basically comprises of palliative care and hospice. Palliative care helps to provide relief from pain and other distressing symptoms. As these patients are suffering from end-stage diseases, these diseases can itself be responsible for causing the pain, and this pain could also be due to the medications and treatments used to alleviate the disease condition. Pain management is an integral part of palliative care in which certain medicines are used to alleviate the pain and allow the patient to live the last days of his life peacefully and actively. Ovarian cancer. Ovarian cancer is a type of cancer that begins in the ovaries. Ovarian cancer often goes undetected until it has spread within the pelvis and abdomen. At this late stage, ovarian cancer is more difficult to treat. Early stage ovarian cancer, in which the disease is confined to the ovary, is more likely to be treated successfully. Symptoms of ovarian cancer may include abdominal bloating or swelling, quickly feeling full when eating, weight loss, discomfort in the pelvis area, changes in bowel habits such as constipation and frequent needs to urinate. Ovarian cancer types are epithelial tumors, stromal tumors, and germ cell tumors. It's not clear what causes ovarian cancer, but the risk factors are old age, inherited gene mutation, and estrogen hormone replacement therapy. So the case study is Gigi, a 40-year-old woman, is admitted to hospice with stage 4 ovarian cancer, metastatic to pelvis, liver, and lungs. She was diagnosed after many months of non-specific complaints of gastric distress and bloating. On laparotomy, she was staged as stage 3 and underwent a total abdominal hysterectomy and bilateral salpingo-oophorectomy and tumor debulking at that time. She has undergone subsequent chemotherapy and repeated tumor debulking. In the past 6 months, her weight has decreased from 175 lbs to 153 lbs. She is 52 inches tall. Her primary complaints are constant nausea, constipation, gripping abdominal pain, which she characterized as burning and twisting. She quantifies the pain as 8 on 10 and describes the pain as one that moves into her groin and leg. Her family is unhappy about the drowsiness from medications. They believe she is over-medicated. She has no known allergies. Current medications are diuretic transdermal system 75 mcg per hour, Q72R, Cadian 50 mg orally once daily, DSS 250 mg daily, Prevacid 30 mg orally daily, and lorazepam 0.5 mg Q4R, PRN, nausea, and vomiting. What is your assessment of her pain management regimen? So the main chief complaints of the patient are nausea, constipation, gripping abdominal pain, which she characterized as burning and twisting, and the pain is also moving into her groin and leg, and drowsiness. The medications that she has been taking are diuretic transdermal system, Cadian, TSS, Prevacid, and lorazepam. The patient is a 40-year-old female. Her weight is 153 lbs. Her height is 52 inches, and she has undergone subsequent chemotherapy, and her ovarian cancer has metastasized to pelvis, liver, and lungs. Patient has stage 4 ovarian cancer metastasized to pelvis, liver, and lungs, and she has been experiencing constant nausea, constipation, and gripping abdominal pain, which is characterized as burning and twisting by her. She has undergone a total abdominal hysterectomy, tumor debulking, and chemotherapy. She has lost 22 lbs weight. She is now a palliative care patient and is getting treated for her pain resulting from her terminal illness. We assess that the patient is using two opioid drugs for same purpose, which is unnecessary as it is producing a duplicative effect, which is leading to drowsiness. And also, in spite of using these two opioids, she is still unable to get relief from her pain. So we can replace these two opioids with methadone, which will be given orally. Methadone is chosen as the patient is experiencing neuropathic pain. Neuropathic pain means that she is experiencing from burning and twisting. And this drug is active against neuropathic pain, and also it has a long half-life. Patient can also experience breakthrough pain. Breakthrough pain is a sudden pain that can arise in patients who are suffering from chronic condition. In order to manage this pain, methadone can be given in small doses if the patient is under medical supervision in an inpatient setting. But as the patient is not in an inpatient setting and can tolerate morphine well, so morphine can be given for breakthrough pain. For constipation, DSS 250 milligram is given daily. DSS is basically docusate sodium. Prevacid, which is a proton pump inhibitor, is used to treat the symptoms of stomach. Lorazepam is used to treat anxiety. So instead of giving two opioids, which is fentanyl or a transdermal system, which is known as Duragesic also, 75 mcg per hour, and Cadian 50 milligram orally 3 times a day, which is producing a duplicative effect and drowsiness, we can give oral methadone at a dose of 60 milligrams per day, which means 20 milligrams of methadone will be given after every 8 hours. Although the patient is relatively young and has been using opioids for quite some time, the starting dose of 20 milligrams every 8 hours can be quite excessive. So the starting dose of methadone will be 15 milligrams 15 milligram orally every 8 hours, making the dose up to 45 milligram per day. And then we can gradually increase the dose according to the patient's condition. Transdermal fentanyl patches are mainly used when there is either compliance issues or when the patient is not in such a condition that he can take the medicine orally. Then we can use transdermal fentanyl patches. For breakthrough pain, 30 milligram or 1.5 ml of OMS 20 milligram per ml can be prescribed after every 2 to 4 hours as required by the patient. OMS is basically oral morphine solution. Thank you.